Good morning, everybody, and welcome to this session on progress on earlier diagnosis in ovarian cancer. It's so lovely to have us with you this morning. My name is Dr. Sharon Tate, and I am the Head of Primary Care Development at Target Ovarian Cancer, and I'm really pleased to be joined this morning by Professor Nigel Sparrow, Dr. Victoria Barber, and Natalie Richarvato. They are our panelists today, and I'm really looking forward to hearing from each and every one of them to hear about their expertise and their insight into the earlier diagnosis of ovarian cancer. So before we start, I have just a few little housekeeping and reminders. Some of these you've heard before. The first one is that we are currently in a webinar mode, which means that your camera and your microphone are not active. We'd love if you could communicate with us through the session and maybe post some questions. If you could do that in the conference platform chat box, that would be really helpful. So in the feed loop chat box, that would be the preference over using the Zoom chat function. But at the end of the day, whatever works for you. Also, we're all here today because we have an interest in ovarian cancer, but I'd really ask you to keep in mind that we are all having a different experience, and we all have different thoughts and feelings. So some of the things that you hear in this session you may feel are relevant to you, and others may conflict a little bit with what your experience has been. But we just ask you to keep in mind that not everybody has lived the same experience as you in their ovarian cancer diagnosis. If you are here today, if you're a friend or a family member and you'd like to ask a question that maybe reflects your friend or family member's experience, then we'd really ask that you get their permission before doing that, just as a courtesy to them. So having said that, I'm going to pass over to our first speaker this morning. I'm really pleased to introduce to you Professor Nigel Sparrow. Nigel has been working with Target Ovarian Cancer since 2014 when he joined our GP advisory board. Nigel has a really impressive and long career in general practice and supporting GPs. There are just too many accolades to mention, but he has recently retired in 2019 from his role at the Care Quality Commission. So I'd really like to hand over to Nigel now to speak to you a little bit about the work that Target Ovarian Cancer has been doing in earlier diagnosis. Thank you and welcome, Nigel.
Thank you, Sharon. I'm going to try and share my screen in a second. It's not working very well. Right, okay. So I'm Dr. Nigel Sparrow, so I'm really delighted to be speaking to you today in my role as Chair of Target Ovarian Cancer's GP Advisory Board. My background has been a practicing GP for over 30 years, and as Sharon said, I've done a lot of work with the Royal College of General Practitioners, where I chaired something called the Professional Development Board, where I was responsible for developing the strategy for continuing professional development for GPs in the UK. As well as overseeing CPD programs. And that's when we developed the e-learning program on ovarian cancer. As Sharon said, I used to work for the Care Quality Commission, where I helped to develop the regulatory system for general practice. So improving quality of care has always been my priority. And at Target Ovarian Cancer, I've hopefully been able to raise awareness of ovarian cancer by liaising with key stakeholders in primary care. And I've supported and helped to develop e-learning educational modules for GPs and nurses. So in this presentation, what I'd like to do is to share with you some of the key areas of progress we're making on earlier diagnosis of ovarian cancer. Currently, too many women are diagnosed late stage of ovarian cancer. On average, only a third of women are diagnosed at an early stage, but we know that there's a huge variation across the country, and in some areas, over 60% of women are diagnosed at an early stage disease. So we know there is a lot of room for improvement. And we know that women that are diagnosed following a hospital referral from their GP have the best outcomes. and yet we still see over a quarter of women diagnosed following a visit to A&E. So these are the three areas that are a priority for improving earlier diagnosis of ovarian cancer. So patients to recognise and report symptoms, that's pretty obvious. GPs to recognise symptoms and refer for diagnostic tests, and systems to improve to support rapid diagnosis. So raising awareness of symptoms and supporting women to discuss these with their primary care teams is absolutely vital. So today I'm going to be focusing on work that we've done to ensure that GPs and primary care teams have the knowledge and information they need to spot ovarian cancer symptoms, and the changes that are needed to ensure diagnostic pathways are in place. So each of these are pretty complex, but there's a lot more that we can do, and we are seeing some progress. So thanks to the wonderful support of many of you in campaigning for change, we have new clinical guidelines for primary and secondary care, including information for GPs on symptoms and diagnostic tests. And this is really important to ensure that GPs have the right information and guidance based on best evidence. So NICE, which is the National Institute for Health and Care Excellence, published for the very first time guidance on ovarian cancer. And this guidance applies to doctors working in England, Wales, and Northern Ireland. And in Scotland, there's an equivalent organisation called SIGN, which revised its very outdated guidance on ovarian cancer to reflect new and emerging systems and symptoms at that time. So for the first time, GPs across the UK now have access to guidance that have acknowledged the importance of ovarian cancer symptoms as a key aspect of early diagnosis. And Target Ovarian Cancer worked closely with NICE and SIGN to shape this guidance. And that guidance now forms the foundation of our educational resources for GPs. Target Ovarian Cancer's Pathfinder research also found that there was a lack of awareness of symptoms of ovarian cancer in GPs. And the charity responded to this by investing in training modules available online for anyone working in primary care. And this has led to the rollout of a very comprehensive education programme that offers online and in-person training, a GP toolkit, and a range of webinars and podcasts. So we've now got e-learning educational modules provided by the Royal College of General Practitioners and BMJ Learning. And both of these are free to access by GPs and nurses in primary care. So since launching the GP education programme in 2010, over 16,000 GPs in the UK have accessed this training. And it's not just in the UK, worldwide, because this is internet-based. 38,000 healthcare professionals have accessed training modules and face-to-face training through podcasts, etc. We haven't just focused on established GPs and nurses, but we've looked at medical students as well. And so in 2017, we launched an essay prize in collaboration with the Royal College of Obstetricians and Gynecologists for training doctors in the future. And we know that medical students have very little direct training about ovarian cancer or specific training. And this prize is really offered to all undergraduate medical students in UK medical schools. And to date, we've had 300 essays, which is great. So the Pathfinder study demonstrated very clearly that GPs were not able to access ultrasound scans as easily as they should. And this evidence secured government funding for access to ultrasound scans in primary care in England. And we've seen now the rollout of rapid diagnostic centres, which are starting to give GPs an alternative pathways for managing patients who have concerning symptoms without a clear diagnosis. We're seeing early diagnosis of cancer as a priority across the NHS. NHS England have now set a target of 75% of all cancers to be diagnosed at stage 1 or stage 2. And we've seen a lot of several awareness campaigns, and we clearly want to see more of those. Primary care networks, which are groups of local GPs, are also required to focus on quality improvement in early diagnosis of cancer. And recently we've seen NHS England committed to developing a timed pathway for ovarian cancer. The development of integrated care systems in England also offers a real opportunity to improve clinical pathways and start to remove the barriers between primary, secondary and social care. So shortening diagnostic pathways is one way that we can improve early diagnosis. And for example, SIGN guidance recommends a simultaneous CA125 blood test and ultrasound. So while it's clear that some progress is being made, we need to go further. We're still feeling the impact of COVID-19, with patients reluctant to access primary care, and also the challenges of working with remote consultations. We're seeing significant changes in how primary care teams and GPs deliver healthcare. Remote consultations, for example, such as telephone and video, offer real opportunities, but also some challenges. There are particular challenges when using remote consultations in managing vague symptoms, which obviously, as we know, are common ovarian cancer presentations. And so safety netting is vital, and knowing when to convert to a face-to-face consultation. Remote consultations can improve access. They can provide opportunities to build strong relationships with patients. And some people actually feel more confident in discussing new health concerns on a remote basis. However, it's difficult to detect cues with body language. It's obviously very difficult to make a visual assessment of a patient's health. So it's important to keep in mind not just the opportunities of remote consultation, but also the limitations and knowing when to change to a consultation in the surgery. So with those screening programs for ovarian cancer, it's vital that we keep up pressure and provide awareness training and supporting everyone to get the earliest possible diagnosis. Over to you, Sharon.
Lovely, thank you so much, Nigel. So I'm going to hand over to Dr. Victoria Barber now. Victoria is a GP. She practices in Northamptonshire, and she's been involved with many aspects of target ovarian cancer's work from 2010. But she's probably best known amongst us for being an absolutely amazing advocate for early diagnosis of ovarian cancer among the primary care community, for talking to her peers and championing ovarian cancer in general practice. So I'm going to hand over to Victoria now so you can hear firsthand about what motivates her and why she's so passionate about this particular topic. Thank you, Victoria, and over to you.
Morning, everyone. I became involved with Target about 10 years ago. It was a fledgling organisation then. I think Sharon said there were 3 stalls in an office, and her and Anwin, I think, at the time. But my mum was looking for support with her ovarian cancer, and she was invited along to one of the get-together meetings. And Target are very good at using the contacts that they have. I think they realised very early on that they had a captivated GP who was motivated to help out, and quite frankly, I was free, so economically, I suppose I made sense. My mum was diagnosed in 2008 at stage 4, and at the time she was told that she'd probably likely to survive only 6 months, but with repeated cycles of chemo, she actually had 5 good years subsequent to that. And obviously that's my background motivation. Because it's a stark fact, isn't it? The earlier the stage that you can diagnose, the better the outcome. And Target very early on identified how this could be achieved with better education of women, better education of GPs, and better access to diagnostics. And the last 2 have really been where I've been utilised. I have done some handing out leaflets at supermarkets with my mum and her friends and things, and that can be quite successful in educating women. But really, my skills have been utilised as a GP. And quite honestly, over the last 10 years, Dr. Sharon Tate and I have had a whirlwind of experiences in the educational field. We started with the British Medical Journal Learning module. That's the audio transmission that, as you heard, had been downloaded thousands of times by people all around the world. Then that led to a British Journal of General Practice quiz module. And then since about 10 years ago, we started at GP conferences. And to date, we've attended GP Pulse, Best Practice, Monthly Index of Medical Specialties, Primary Care Group Educational Afternoons. We've given talks. We've manned the Target stall to field questions after my talks and for people wandering around picking up leaflets. Quite frankly, we've been a presence and an irritation wherever GPs have been educated. And over the time, we've listened to feedback and we've learnt to give GPs what they need in a succinct fashion as we possibly can. I've used examples where diagnoses have been missed, possible pitfalls, the subtle cues, and we've always responded to our feedback, which thankfully has pretty much always been positive. And if you do the question, how confident do you feel about diagnosing ovarian cancer before and after, you can see after the lecture the confidence rating has completely shifted. And over the time, Sharon and I have had to adapt, same as the NHS has really. We've developed learning tools and specific educational input for nurses and nurse practitioners who, as you well know now, are increasingly the triage team as GP numbers continue to fall. So we've made advice sheets for these healthcare professionals, and we've incorporated them in our talks. We fought also behind the scenes for better access to CA125, which even after NICE, took ages for us to be able to get proper access for GPs. We've educated GPs about transvaginal scans, which is the type of scan you need to do. And of course, over the last couple of years with COVID, we've had to move online. We've done podcasts, we've done lectures live. These can be downloaded afterwards. We've had to develop specific guidance for GPs who are using these online and remote consultations and the potential pitfalls in those particular things. Because it's so important to get grassroots GPs on side. I'm a jobbing GP in a relatively poor area, and I can relate to the time pressures of a surgery and what has to be achieved in those 10 minutes that you've got for a consultation. And in the past, so often, education has come from specialists who don't quite understand the challenges and the time pressures that GPs face, and it isn't terribly constructive. So I've honed my skills directly, really, from women who've been misdiagnosed, and I feel that I'm their advocate, really. I've listened at conferences and things that Target have arranged to women's stories that illustrate how badly things can go wrong, where people are told that they've got irritable bowel, they've got indigestion, urinary infections, and these narratives directly from your feedback, from your women's stories that Target hear, or from conversations that I've had with you at Target's get-togethers. They're so important, and it gives you a voice and a way of directly influencing doctors' thoughts and their diagnostic acumen. And I can't thank you enough for your stories, because it's been really, really helpful to illustrate my talks and get the message across. Apart from the educational role, I've tried to come up with ideas sparked by my experiences. We've got things like pop-ups of data entry, trying to get data companies on side, helping to try and guide the Sowerby project that you can hear about at an early stage. I can't begin to tell you how awful the IT systems are within the NHS. They're so complex and so often they don't talk to each other. But finally, we seem to be having a breakthrough and we seem to be getting a system that's more worthy of the 21st century, but watch this space. I'm also a member of the GP Advisory Board with Professor Sparrow. I try and give constructive feedback for what will work within the context of general practice in its current form. So the whole point is so that we don't waste money on schemes that could fail at the first hurdle. It's just that important input of just an ordinary GP in that background. And throughout my time, I mean, I know what's going on in the press at the moment. I know we're getting slated. I know we're struggling to get access for you, and bear with us. It's going through a difficult time. But I've met many motivated and lovely GPs who do want to do their best to avoid misdiagnoses and improve early diagnosis. And we've spoken to the conferences, and quite frankly, we've recruited them in turn, and we've got a GP network that Sharon has set up, and we've got these people on board as well. And in summary, really, it's been an absolute privilege to work on your behalf over the last 10 years and in my role in educating GPs. And I'm hoping very much that Target will continue to allow me to do so. So thank you very much.
Oh, thank you so much, Vicky. We will certainly have you on board as long as you're willing to give us your absolutely precious time. Right, so I'd like to hand over to Natalie Richarvato now. Natalie joined Target Ovarian Cancer just over a year ago as our clinical change manager, and she leads on a really important project for us, which is identifying and breaking down barriers to early diagnosis of ovarian cancer. This is a really significant project for the organisation, and we are really fortunate to have funding for this from the Peter Sowerby Foundation, to whom we are really grateful. Natalie's work spans working directly with colleagues in the NHS, and she's working with them to develop new approaches to improving and accelerating ovarian cancer diagnosis in primary care. So without further ado, Natalie, over to you. Thank you.
Thank you, Sharon. So today I'll be just running through a bit about our work as part of the Peter Sowerby project that's called Breaking Down Barriers to Early Diagnosis. I just have a few slides that I'll share with you. Okay, so breaking down barriers to early diagnosis. So Nigel mentioned a bit about this at the beginning, and Vicky as well. So why do we have this project in place? So this project has been really kindly funded by the Peter Sowerby Foundation, and the aim is to address regional variation in early diagnosis. So why is this important? This means that we want women everywhere, no matter where they live, to have an equal chance at early diagnosis. And we want to develop the support and tools that GPs, primary care commissioners need to enhance earlier diagnosis. So we are looking to achieve the same level of excellence across the country. And this is a dual phase project, so 2 stages to this. So the first phase, we undertook some research, so a research kind of deep dive in different areas of the country. So the higher performers and the lower performers in early diagnosis, so diagnosis at stage 1 and 2. And we wanted to understand what the differences were. So what are the people, the GPs in the areas that are doing really, really excellently? What are they doing differently to other areas of the country? What support might they have? What tools might they have that might not be available elsewhere? So we want to take that knowledge and build and design some interventions based on those findings and test and evaluate them in other areas of the country. So our research highlighted some really key areas for us to focus on and focus our intervention and design around. And yes, as I said, so we researched the most important people that we could get this information from. So absolutely GPs on the ground, people that are involved in the commissioning side, so responsible for the design of the pathways and commissioning services in their local area. So our key focus areas that we discovered in our research were around data. So reviewing data, using this as a bit of a basis for developing quality improvement. So if you don't know how you're doing, how can you improve as an area? Safety netting as well. I know Nigel mentioned a bit about this. It's a real focus area. It kind of goes into the next point around technology. Given the move to remote consultations, a lot more dependence on GPIT. These two areas are really working together. So there's some really good ideas that you can develop around how to safety net patients with symptoms, test results, referrals. So it's all about following up with the patient. There's also new routes to diagnosis. So things like using rapid diagnostic centres. And we took all of this information that we found. We had lots of really great responses in our research, and we developed a research report and an animation for commissioners and primary care. So this had an amazing response. We sent this out nationally. We created a commissioners area of our website, in which you can find the report and animation. And this information in the animation and report really highlighted some of the messaging we have that we want commissioners and primary care to know about some of the challenges that we found to early diagnosis, some of the gaps where we think there could be improvement measures taken, and some of the successes, so some of the things that we would suggest. And this was kind of sent out as a bit of an invitation to say, this is what we know, this is what we've realised, and we want to take this into phase 2 and work with you in partnership to develop and test some of our ideas. So we've got some really great ideas from our research. How can we build on those? How can we develop those? As part of this as well, we had an amazing response from our target ovarian cancer campaigners. So there was an e-action for our campaigners where they could share our report and animation as part of an e-action to their local CCG. So that had an amazing response. So thank you to everybody that was part of that. You're really helping to spread the word. And we have now some pilot sites that we're working with across the country to work in partnership to test some interventions as part of phase 2. So how are we doing this? So we're working with NHS organisations across England, and we are developing systems and tools, as I said, based on our research findings that will aid earlier diagnosis. So from our kind of focus areas, we're narrowing this down now to some focus areas that we're going to work in partnership and monitor and evaluate some techniques. So technology, a real big focus area, as I said, so we're safety netting results and symptoms. We want to improve follow-up for women as well. So we want to try and standardise the process for women with symptoms of possible ovarian cancer. There could have been a risk in the recent, say, last 6 months of the patient's possible misdiagnosis, things like IBS or diverticulitis. We want to follow up with those women and test some methods where we can easily get in contact with them and bring them back to primary care for further investigation. We'll also be doing something really fantastic, really new, that's not been done too much before, around bringing together primary and secondary care partners to develop a kind of dual education and learning programme. So we found in our research that there's a bit of a divide between primary and secondary care and their communication with each other. So we would really love to develop an education programme that brings together their concerns and trashes it out for a bit of a Q&A so that we strengthen the partnership between primary and secondary care. We'll also be looking throughout our kind of technology interventions. We'll be looking at how we can automate processes. So as Vicky was speaking about, we've had during the pandemic a huge advance on what the capabilities of GP IT are. So we want to make sure that primary care are using this to its highest potential. So what can these systems do? How much can we automate? How much can we use algorithms to pick up on women? and in that case we'll be ensuring that more women are recognised with symptoms and therefore diagnosed faster. So we have developed our project in partnership with clinicians. So we had our research from phase 1 and we've taken this and now we are having conversations with commissioners, with primary care. We're working with new networks as well, so primary care networks as part of their quality improvement recommendations. Will be creating some really impactful and long-lasting interventions. So how will we take our findings from this pilot work and how will we use this information? So this work will help identify best practice. If we're testing new techniques, new interventions, we'll be developing a best practice portfolio. So we'll be building a kind of folder of all of the things that have been really effective. We'll be listening to GP feedback as we go. We'll be looking at things like GP confidence, how much they feel these systems have supported them and their patients. And we'll be using this as an opportunity to really kind of shine a light on what we found. So what has worked? What would we recommend be implemented in other areas of the country that we haven't partnered with? We'll be able to offer a kind of portfolio of solutions for early diagnosis. So these techniques will be a way to introduce kind of tried and tested methods as well. So we'll have an evidence base that we can then share nationally and encourage other organisations to learn more about early diagnosis, and we will be able to show them what's been most effective. Thank you very much. I think I'm going to hand back to Sharon and Nigel now.
Thank you, Natalie, for giving us a really interesting insight into the work that you've been doing over the recent months. We're just going to hand back now to Nigel to give us a couple of final reflections on maybe the future of primary care and early diagnosis of ovarian cancer in primary care. And then we will move on to any questions that you may have for us. So back to you then, Nigel.
Thanks, Sharon, and thanks, Natalie and Vicky. What a fantastic session. There's so much work that we're doing and so much more to do. Natalie's outlined all the things that we're planning to do now, and it's really an exciting time. So if we start thinking now of what the future of early diagnosis is all about, so we're going to be continuing, as Natalie said, to support GPs to update their knowledge. We've recently, for example, been working with the Royal College of GPs and BMJ Learning to update and revise the learning programmes to reflect the use of safety netting, remote consultations, and the importance of face-to-face consultations, as we've described. There are new interventions and streamlining diagnosis. So we've heard about the rapid diagnostic centres. We've heard about the work that we're doing with SABI and the work that will follow on from that. We'll be engaging with GP networks and integrated care systems to improve access to investigations and streamline diagnostic pathways. I've always felt that the sort of divisions between primary and secondary care have been completely artificial. From a patient's perspective, there shouldn't be any difference, really. It's a straightforward pathway. In reality, it's not. So integrated care systems do have that potential to remove some of those barriers, and we hope that'll work. There's new approaches to diagnosing cancer, and it's not just about primary care. So, for example, Target Ovarian Cancer's funded work by Dr. Elizabeth Moore has done, showing that just small levels of DNA from ovarian tumours can be detected in blood from women with early diagnosed ovarian cancer. So there are real opportunities for the future, and that's really exciting. So where do we go to now? So what can you do? So you could, for instance, tell your GP about the training modules. Share your experience with your own practice, and remember about the patient focus groups that you could organise perhaps during cancer awareness, ovarian cancer awareness month in March. So these are the sort of things that we're going to go for the future. I mean, it's been a really exciting session, and I'm going to hand back now to Sharon, and then we can perhaps get into some discussion.
Thank you, Nigel. Okay, so yes, we do have a couple of questions that I am going to put to the panel. So we have our first question is, I think, just Nigel, at the end there, you reflected upon some of the steps that we could take as a community in terms of supporting awareness amongst GPs. But Vicky, I just wondered if you'd like to build on that from your perspective of working at the coalface in primary care and the work that you've done. What do you feel that we could do collectively or as a community or our own individual selves really to expand the work that Target Ovarian Cancer is doing?
I think engage with your GPs first and foremost. I mean, if you've already had a diagnosis of ovarian cancer, I think use your story, to be honest. From personal experience, my mother's experience was invaluable. We set up educational posters in the waiting room, for example. I raised money for Target through using her story, and the local press got interested. Go to your surgery if you've got ovarian cancer and say, look, can we use the March awareness campaign? Can I hand out leaflets? Can I tell my story to people that come into the building? Can we put something on your Facebook page, on your website? So those sort of constructive things I think would be really useful. If you don't have ovarian cancer, but you're worried about it, and you're going to see your GP as a consultation, please mention the fact that you're concerned about ovarian cancer and encourage your friends to do so, because so often that's really, really helpful to GPs because then they know what you're most worried about. And they've got a starting point to make sure, darn sure, that they exclude ovarian cancer as part of your diagnosis. And ask your surgery if you can hand out leaflets, put them in the waiting room, put something on the TV display board. You can really sort of integrate with your practice manager about those sort of things, because often they're looking for information to get out to patients. They're looking for those patient stories to show that they're also part of the community. So that's what I would personally recommend.
Thank you, Vicky. We have had a question put to us. It's regarding, I guess, how common ovarian cancer is. So the question is, ovarian cancer is classed as one of the uncommon cancers, and GPs therefore do not think of ovarian cancer when they present with symptoms. Would you say it's now a more common gynecological cancer? Well, I think I'll kick off with this one, but then perhaps Nigel or Vicky, if you'd like to chip in on that, then feel free. Can see Vicky's got a hand up already. So within the context of the gynecological cancers, we have a similar number of cases each year of both ovarian and cancer of the womb or endometrium, whichever way you want to think about that cancer. So they are similar in terms of the number of new women diagnosed every single year. The challenge is that uterine cancer or womb cancer is much more easily recognised by primary care and has historically had clearer pathways for managing women and getting them on the diagnostic pathway quite quickly. It's much, much harder for a GP to recognise ovarian cancer symptoms amongst the really common symptoms that they're seeing in general practice every day. So ovarian cancer isn't necessarily becoming more common, either in its own right or amongst the gynecological cancers. I think what we are doing as a community is putting more emphasis on it as a cancer and giving it greater recognition, bringing it to the fore and helping people understand, both in primary care and also in the general population, why we really need to be thinking about this cancer. So Vicky, I could see that you had something to say on this as well, so I'll hand over to you.
This is one of Sharon and my burning areas of concern. Really, it's not so much that ovarian cancer is increasing; it's how we need to view it, and we need to stop trying to pigeonhole it into some sort of wonderful gynecological cancer, because that takes the emphasis away from the symptoms. And very much when we do our educational things, we're trying to sort of sell it as a tummy cancer. With abdominal symptoms. So this is why it gets misdiagnosed, because people unfortunately get labelled into these specialties, and people forget that if you're referring somebody to a gastroenterologist, or if you're going to a gastroenterologist to have tests on your bowel symptoms, you should also be tested for ovarian cancer as well. And I think that's absolutely vital to get that across, because unfortunately, sometimes there is an element of people going to, say, women GPs for women's problems, and I think it's very important to not see this as a gynecological cancer, because of the nature of its symptoms are very, very different to cervical or endometrial cancer, which very much present as bleeding, which obviously women have, and those are very specific, whereas ovarian cancer is far more subtle than that. So that's what I would suggest, is that we need to get away from this gynecology pigeonhole, and that's where the misdiagnoses come.
Thank you, Vicky. So just kind of following on from that a little bit, I would just like to reflect that within the 13 years that I've been working in this organisation, I've seen a massive shift in attitude towards ovarian cancer amongst the GP community. We've gone from something previously that people were absolutely terrified of, in the context of, well, there's not a lot I can do about that. I can't really change this process. I don't have any power to improve this situation. But we've completely moved to the other end of the spectrum now, I'd say. When you and I go out and we go to conferences, there is a huge appetite for information, and the kinds of comments we would get from people are, oh my goodness, this is the one that really keeps me awake at night. I'm really concerned about this. How can you help me? How can you support me? So I've definitely seen that shift. But Natalie, I wanted to bring this back to you a little bit through your work, because I know when you launched the report and animation in June, we had an absolutely amazing response to it. I think far more than we ever could have anticipated. So just from your work over the last few months of really engaging with healthcare professionals and the primary care community, can you just give a sense of the experience you've had?
Yeah, there's been a huge appetite from lots of different health professionals getting in touch. So not only have we been engaging with CCGs, from people that work at that kind of admin level, we've also had some really fantastic responses from just individual GPs getting in touch just to find out, what can I do? And one of the most interesting things I think that we found is those that have been really empowered to make changes, make improvements in their own local systems, have seen a patient with ovarian cancer perhaps not picked up on symptoms as quickly, might have had a personal experience with misdiagnosis, so they are really empowered to make those changes and work with us, build on education and awareness and understanding what they can do. But we've had an absolutely fantastic response really across the map. It's been a lot more than we anticipated, I think, Sharon, isn't it, when we first kind of set out on this journey?
Well, absolutely, Natalie. I think in some respects, a lot more interest than we could possibly handle. So it presents a nice challenge, but how do we manage that situation? Nigel, I'd just like to come to you for a moment. You gave us some reflections there at the end in terms of opportunities with regards to early diagnosis, but I wondered if you could maybe pinpoint what you see really either on the horizon or maybe something that's happening now that you feel will be the most important thing, in your opinion, for making sure that everybody receives the earliest diagnosis. And I know that's quite hard to maybe bring it back to one. So if you've got a couple.
Yeah, so I think, first of all, I think it's coming back to this, the COVID-19 work, what's happened since COVID-19. And we have seen the change in the pattern of consultations, and that's not going to, although we will see more face-to-face consultations, remote consultations are here to stay. I think they've been here forever. We've always used telephone consultations. But actually, we need to do a lot more work on the opportunities of using this type of consultation. So I think that's the key thing. And coming back to this issue of how common ovarian cancer is, if you don't think about it, you'll never diagnose it. And so that's the key thing here. And I think, we just need to keep pressing on with the same messages that we have done. It doesn't matter about how the consultations are done. If you don't think about it, you'll never find it. So even though you may not diagnose many cases in a year or 5 years, that doesn't matter as long as you've done the tests. And if you get a negative normal CA125 and your suspicions are still high, don't give up on thinking about ovarian cancer. CA125s are good, but they're not that good. So those are the sort of messages I think we need to get over.
Yeah, absolutely, Nigel. Thank you. We are drawing to the end of this session now, so I do have one more question I'd like to put specifically to you, Nigel, but again, Vicky, you might have some reflections on this. I think people with us today will have been put in a situation where they've had to advocate for their own health. They've had to keep knocking on the door to get to the bottom of their diagnosis when things maybe haven't been as straightforward as anticipated. In your talk, Nigel, you did talk a little bit about the challenges of remote consultation, and you touched on it then with regards to it being part of the norm now for general practice. Can you just give us, and you gave us some ideas from the GP perspective, but can you just reflect maybe on the patient perspective, how a patient can facilitate a remote consultation appointment? Is there anything that they can do to be prepared for that situation?
So I think it's a bit like when you do a face-to-face consultation. The more work the patient coming into the surgery, to think about and structuring the things that they want to say. There are opportunities, I think, with a remote consultation whereby you're in your own home and you can think about things a bit more. You're not intimidated necessarily by coming into a surgery. And some people are still, concerned about going in to see a doctor in the surgery. But you're in your own home, in your own secure environment, and it gives you the opportunity to structure those thoughts and get them written down. Write things down before the consultation. Have your notes ready. You may not think it's important, but GPs work by pattern recognition. And when you see a collection of symptoms, which somebody might not think is desperately important, but when you put it all together, it paints a picture. And that may mean getting some tests done. It might mean bringing somebody into the surgery to examine them. Sometimes you don't need to examine. Sometimes you can do things by investigations and make the diagnosis without it. But you need to, so from a patient's perspective, it's important to structure those thoughts before you start the consultation. There are improvements in remote consultations whereby you can get access a bit quicker. So instead of saying, well, you've got a 2 to 3 week wait for a consultation, you might get a telephone call the next day or the same day or whatever. Certainly an awful lot quicker than a face-to-face consultation. So don't chuck it out. Just remember, this is a real opportunity to talk. And the more you say, the more the GP will be able to get to the right diagnosis.
Lovely. Thank you, Nigel. I can see we are really coming close to the end of our session now, so I am going to have to bring it to a close. So I'd just like to say a huge thank you to Nigel, Victoria and Natalie for their fantastic presentations today, and also all the extra insight they offered us through that question and answer session. And also just to say thank you very much to everybody who has joined us today. We really appreciate it, and we really appreciate your input, your questions. And I'm sorry if any questions have got missed as a result of us having to bring the session to a conclusion now. But just remember, if you do have any specific concerns that are personal to you, or you just like a chat and you need a little bit of support, then our support line is available. You can call us on 020 7923 5475. But thank you again for joining us, and I really do hope that you enjoy the rest of the conference. Thank you.